Today we'll be talking about some of the upper causes of GI bleeding. You guys know this is one of my favorite topics. It's definitely a bad topic in emergency medicine. So these are the things we'll talk about today. We'll cause the causes of upper GI bleeding. We'll talk about the pathophys, how to make a diagnosis, and then some treatment modalities. So here's a good list that you guys should start off with as your differential diagnosis whenever you see an upper GI bleed. I won't go through them, but you guys should know this by now. So let's talk about malleable Weiss tears. It's less than 10% of upper GI bleeds, and it comes from repeated retching or vomiting, and it's only a tear of the mucosal layer. They're usually pretty self-limited and don't cause many issues. Treatment, as you can imagine, stop the vomiting, give antiemetics. There's no data in the literature about which work best, although my personal preference is if you're a diabetic, I give Reglan because it has the added side effects of gastric motility, and people who have diabetic gastroparesis, this may help them. But there's no real good literature that shows that any one of them works better. So GI rest, H2 blockade, PPIs, and then most people think of malleable Weiss tears as pretty benign. But one paper I read said a certain number of people will have to get endoscopic banding of these malleable Weiss tears to stop the bleeding. I've never seen anything so severe in my career. Nobody I've talked to has either, but just realize that there's literature out there. It's not always totally benign. For gastritis, basically, you're not penetrating deep. You're not going through the mucosa into the muscular layer. It's usually thought of as pretty benign also, although this one paper said 6% requires surgery and 2% mortality, with almost a 4% mortality in the elderly. Shout out to Dr. G there. But again, this is a paper written by surgeons. So surgeons got to cut. The cutters want to cut. So take it with a grain of salt. The common causes of gastritis are usually infectious etiologies, drugs, and alcohol. Treatment of gastritis, remove the trigger. Get them some GI rest, H2 blockade and PPIs, Malox. And one of the new drugs that I came across in reading the literature is vonoprazan. Anyway, this is a competitive inhibitor of the ATPase-driven K plus H plus antiporter. And this is the enzyme that makes the acidic environment in your stomach. And it competitively inhibits that. So maybe it's a little bit better than the other H2 blockers, but definitely more expensive. I don't believe we have it on pharmacy here, so not very helpful to us, but just know it's out there. And then one other thing I read was ribamapride was also ribamapride is another drug that people use, but this is only available in China. This is actually an interesting drug because it increases gastric mucosal secretion of both PGE2 and mucus. So it makes a much better barrier for the stomach and prevents you from getting gastritis that way. You guys should all memorize this list of your bloody diarrhea causes that are infectious. We all did it in medical school, so I'm not going to go through it that much. One interesting one I did come across was that Klebsiella oxytelca was antibiotic associated. So if you have recently taken antibiotics and you get bloody diarrhea, it may do to Klebsiella, not C. diff like we usually think. Treatment, mostly self-limited. Most people do not need antibiotics, although we used to give this back in the day, but most people don't. The only three cases I found when you should give antibiotics is if you have C. jejunum, and then you should give the Zithro. There's many cases of Bactrim and quinolone resistance now out there with these new bugs. Infants less than 3 years old, they should get antibiotics. And if you're going to give them, it should be a cephalosporin third generation, not a Zithro. And then if you're immunocompromised HIV, you're probably going to give them antibiotics as well. If they had recent antibiotics, then think of C. diff and fidaxomicin and P-Vanco were used for that. Fidaxomicin had a much lower recurrence rate than P-Vanco, so that would probably be my choice if we can get it. I think you just need ID approval for that. If you have the E. coli that makes sugar toxin, you really should definitely not give antibiotics because you have a higher chance of getting HUS. People with peptic ulcer disease, these are erosions into the wall of the stomach and duodenum. Most people think that the ones in the stomach are painful and the ones in duodenum are painless. Not totally ever been proven to be true, but That's what most people believe. If you're age 50 or older, you have 5 times the chance of having peptic ulcer disease. I definitely believe that. Most common causes are drugs, acid overproduction, and H. pylori. I have yet to see a case of Zollinger-Ellender syndrome. Well, let me restate that. I have yet to make that diagnosis. I may have missed it and had a case, but I have yet to make that diagnosis. This is a nice chest X-ray of somebody with a complication of peptic ulcer disease. These people are perforated, and you can see here that there is a very nice air under the diaphragm, very well outlined on the right side, silhouetted under the liver, and the left side over the gastric bubble. But also notice that some of the air has crept up into the chest, and you can see a nice outline of the cardiac silhouette right there, pointed out by the red arrows. Symptoms usually is a burning pain. We see this almost every day we work. People with peptic ulcer disease and people with GERD, but it can present as painless and just presents as symptomatic anemia. If they have very brisk bleeding, they may get hematemesis or hematochezia, and in some cases with bad bleeding, melena, where you have all the blood is digested out into a very dark, tarry stools. I'll talk briefly about H. pylori just because it's so common and is probably the leading cause of peptic ulcer disease. This is a gram-negative microallophilic bacterium. We all know it causes peptic ulcer disease, but it also can lead to gastric cancers. Impressively, 50% of the world is infected with this bug. It lives in the mucosa of your stomach, so the definitive way to make the diagnosis is, of course, biopsy. However, nobody wants to get a scope and nobody wants to be this invasive. So there are a bunch of other tests to look for it, right? You get the blood antibody test, there's a stool antigen test, a urine ELISA test, and then we talk about the breath test every now and again. The breath test relies on the fact that H. pylori has an enzyme called urease. And what urease does is it splits urea down into CO2 and ammonia. So if you give them carbon-14 labeled urea, when the bacteria splits it, they breathe out the carbon-14 labeled CO2. So it's very easy to test for that. The other place we use this is in people who are being treated for H. pylori. We can test to see if treatment has eradicated the bug by the change from the carbon-14 urea test to being positive to negative. That's when you know they're well treated. So treatment with peptic ulcer disease, again, is PPIs, H2 blockade, and acids. Again, if you can get vinoprazan, that's a new drug that's out there. You can give sucralfate to coat the stomach and help make the ulcers less painful. And then you have your quadruple therapy, which is bismuth, PPI, tetracycline, and metronidazole. Realize that the PPIs are twice a day, but the other 3 drugs are 4 times a day. And it's sometimes hard for patients to keep up with that regimen. Diet modification is also helpful. And a lot of places I read about smoking cessation and PUD. I don't usually think about this when I'm working, but there's a lot of data out there that shows that smoking causes less epidermal growth factor, so slower healing, less gastric blood flow, so slower healing, plus histamine, pepsin, and secretion, and then decreased mucus production, and also proliferation of the H. pylori for some reason. So smoking is a really bad factor for PUD, and you may want to encourage your patients to quit smoking or at least start them on the patch so they can smoke less while they're getting over their PUD. Some other causes of gastric bleeding are esophagitis, especially from GERD, AV malformations, gastric cancer, and then occasionally foreign bodies leading to trauma can cause some bleeding in GI tracts. So what kind of foreign bodies have you guys seen in your career? I've seen quite a few now, and I put this in here for mostly for entertainment reasons and just to give you a little break from thinking, but we'll go through them and see if you guys can identify all the different foreign bodies we've seen. This one here, very interesting guy who came in with belly pain, and you can see on the x-ray here, he has his bridge or his false teeth down in his stomach. Here's a good one. This guy worked in a home demolition on his own house, and he was picking up carpet. And after he pull out the carpet staples, he would hold them in his mouth and throw them out. But unfortunately, he swallowed 2 of them, which ended up being very painful for him because they probably scratched the esophagus and or his stomach when they went down. Here's a little kid that has foreign body. You guys identify this one. That's right, it's mom's earring. Here's one you don't want to see. All right, this is a straight pin. This is just a case of a person who swallowed a needle, but unfortunately it got down through the GI tract partially, and then it perforated the GI tract. Ended up looking just like appendicitis. They had right lower quadrant pain. But when we filmed them, they ended up having this foreign body on their film. This is a good one. If you're going to swallow a pin, this is the kind you should swallow, right? These are safety pins, no sharp side to them. Yet another working in the garage mishap, a sheet metal screw. And this one was pretty impressive. This kid swallowed mom's whole entire jade bracelet. This guy was pretty funny. He was playing dominoes with his buddies and didn't want to get caught cheating, so he swallowed the evidence. This is a really old film. This is one I took when I was an intern on the trauma service. And what would happen is people in prison would tape up a razor blade and then swallow it. And then they complain of belly pain and get taken out of prison to the prison ER or the prison inpatient floors, which was in our old building in the B building, I think on the third floor or A building, third floor. And they would sit there until the razor blade passed in their stool. This is one that Noah just finished talking about. These are our button batteries. You can see the double ring sign. Here's a weird one I saw. Yeah, Phillips head screwdriver got in there somehow. 1 in a million chance. This one's interesting because the metal clips are from the cholecystectomy, but the foreign body is pretty much the same density as the rest of our body. This is not synthetic. There's a nice cucumber there. This one a little bit more dense than the human body. Synthetic latex. And of course, this one was super interesting. You guys can all see the outline. Here's you got your toothbrush with their carry case. It's always impressive to look at the mechanics behind this stuff. Here you see your electric toothbrush with AA battery in place, a motor right after it, and then a spindle that's off-centered with a rod that drives the head of the toothbrush and makes it vibrate. Common stuff like drinking glasses, or this one, a garden sprinkler. This was a Fast Track a couple years back. Anybody recognize that? Spray deodorant. And then another one that nicely shows mechanics. Here's a vibrator. Notice it has two AA batteries, not one, more power, a bigger motor, and then a little metal weight that's off center that when the motor spins around, it makes a vibrating feeling. And of course, my favorite GI case I've seen, you guys all recognize this one. That's right, Buzz Lightyear. No idea how it got there. Anyway, let's get back to the lecture. So treatment for non-variceal bleeding is to resuscitate the patient, right? Give them IV fluid, give them blood. I encourage you guys to put them on the rapid infuser so it goes in heated and it goes in quickly. They should all get scoped in the first day or so. And you can give them PPIs and H2 blockades to calm down the stomach. Again, vamopressor to help with acid secretion. And if they have a tumor or a deltoid lesion that's bleeding, you may want to consider endoscopy sooner. These guys will benefit from being clipped or banded, and that does much better than epi injections do. I did read about this new device that's a topical hemostatic powder injector. Basically, what it does is a scope goes in and looks at the ulcer, and then you put the plastic tube of the gun down the scope, and you pull the trigger, and it shoots the powder over the bleeding part that's coming out, and it's got stuff like quick clot in there that helps them clot off. All right, let's switch gears and talk about esophageal varices now. So esophageal varices are a bad disease, in my opinion, and most other doctors too, but it's recurrent. 60 to 70% of these guys will actually have rebleeds. 30% will go to surgery, and a third of all GI deaths are caused by esophageal bleeding or esophageal variceal bleeding. They should be scoped early and not late. And the big complication of varices, or the cause of varices, is cirrhosis, which is usually due to alcohol or hepatitis, one of those two, with the big problem being portal hypertension. When the portal pressures go up, it diverts blood away from the liver and towards the systemic side. So where are your systemic crossovers in your GI tract, right around the esophagus, where the esophagus meets the stomach, that gives you your varices. At the anus, so you get your hemorrhoids, and around the belly button, that gives you caput medusa. So how do you make your diagnosis of esophageal varices? Well, the gold standard is endoscopy. But these are kind of tough on the patient and on the doctor getting GI to come in. So they have other ways to do it too now. They have capsule endoscopy where you swallow this big pill and it takes pictures going down and then it sends them off to a computer and you can review them later on. Also, your favorite and mine, color flow Doppler. This is transabdominal, and you can look at flow rates and get a little information about how much risk the varices are for bleeding. And then, of course, you have contrast CTs and MRI as well. So who's at the most risk for bleeding? Well, it may depend on variceal size. Anybody over 5 millimeters who has a flow velocity over 20 centimeters per second, these guys are at risk for bleeding. People who are still actively bleeding, actively drinking, they're at risk for bleeding. And then a lot of places in the literature, I saw these red whale marks come up. They say they look like corduroy. I looked all through the literature. I could not find a single good picture of them. This is the best I could do, but just know they're out there. People with platelet counts below 110,000 have risk for bleeding. And then portosystemic pressure gradients of over 20 millimeters of mercury. These guys also have risk for bleeding. We talked a little bit about this earlier today. This is your Glasgow-Blanchard score. This is your pre-endoscopy and preclinical score. You don't need any labs or anything. This is just a score, but what it does is it looks for the need for clinical intervention. So if their score is low and they have no need for intervention, maybe you can send them home. It doesn't tell you anything about mortality. So it looks at the hemoglobin, the blood pressure when they arrive, the heart rate, if they have melena, if they had a syncopal episode, if they have liver disease or CHF. And these are all things you'll know right away, within walking in the room or a couple minutes after getting your labs back. This is a very easy score to calculate. So the literature I read, it says if they're 0 to 1, they're safe to send home. And this is actually relatively new compared to the older literature that says only scores of 0 can go home. But this paper that I read said 0 to 1 can go home. 2 to 5 is moderate risk and they should be admitted, and they should also be scoped within 24 hours. And then if you're over 6, these guys end up doing very poorly. They probably should be transfused early. They should get early endoscopy, and maybe they should be admitted to the ICU. You can compare this to the Rockall score, which requires endoscopy. This tells you what the source of the bleeding is, and it will also give you an idea about mortality. But it's a much later in their visit score, probably inpatient. So it doesn't really help ER doctors that much. So if you're not bleeding, treatment for varices is probably a non-selective beta blocker, maybe carvedilol, PPIs, H2 blockade, maybe somatostatin. Some papers say TXA works, some say it doesn't. I think if you're really worried about it, it doesn't hurt to give it, although it may not get much benefit out of it. And then, of course, behavioral modification, stopping the drinking if that's the cause. I do want you guys to realize that no drug has an FDA indication for GI bleeding. Every single drug we're using here and talking about is off-label use. So nobody's ever been proven to do much by the FDA. If you're bleeding, this is a whole different ballgame, all right? A lot of these people are bleeding so badly, you probably want to intubate them, take their airway, make sure blood's not going down into their lungs. You want to get an IV set up and start them running on saline while you're getting their blood ready. You want to type and cross them for 6 units. And if they're bleeding really bad and they're hypotensive, you may want to consider MTP. Maybe you want to put some FFP and vitamin K in there to reverse the coagulopathy of liver disease. Think about medicine, endoscopy, and then we'll talk about balloon tamponade surgery and portal pressure reduction as well in a minute. If you're going to do endoscopy for bleeding varices, it really needs to be done within 12 hours. The earlier, the better. But sometimes it's hard to get surgery to come in. To get GI to come in and do this. And then, of course, you want to think about your portal pressure reduction. But that's once the patient is stabilized. Nobody's going to put a patient on an invasive table to do these procedures until they're stable. Medical management, somatostatin diminishes portal blood flow. This is a good drug, good drip to start. It causes vasoconstriction and pushes blood from the periphery back towards the portal side. Sandostatin is and vasopressin are also helpful. And then I read a paper on terlipressin, which is a synthetic vasopressin analog, but it's really used only in hepatorenal syndrome and only available in Europe. Of course, all these patients should get ceftriaxone. This has actually been proven to work in multiple papers where it reduces rebleeding, it reduces infection, and it reduces mortality. This is super important that we give this in the ED. Transfusing people, most of us will start at a trigger of 7 to 8. Maybe consider a higher trigger if they have coronary artery disease because you don't want them to get ischemic. But realize that it will raise their blood pressure and may push off clots that are already forming, so it may worsen the bleeding. Maybe you want to add FFP and platelets as well while you're transfusing them in massive transfusion protocol. Endoscopy super helpful. A lot of times they'll start with sclerotherapy. From what I read, sclerotherapy is not great, has a lot of complications, and often fails. So most GI people will go straight to variceal ligation with banding. If your portal pressures are not that bad, banding has a much better rate than sclerotherapy itself. I did read one paper on variceal obturation where they put tissue adhesives on the bleeds, but 5 to 10% will fail and end up requiring surgery. So most of the GI guys won't do obturation. Here's what banding looks like. Most times they'll put on 2 bands just in case one falls off, and they'll try and band off that variceal bleed. We all like to talk about the Sandstake and Blakemore tube and put these in for GI bleeds. Just realize that if you've gotten to the point where you're putting one of these tubes down, your patient's probably in a lot of trouble. The stuff you need to know about it is it's a 2 balloon system where one balloon is volume based and one balloon is pressure based. It is a last resort and should not stay in there more than 24 hours. There is a second tube called the Minnesota tube, which looks just like the Sandstake and Blakemore tube, except it has a port down there between the 2 balloons. So when you have the bottom balloon blown up and nothing can get out into the stomach, you can suction out all the blood that's pooling in the esophagus. It's a little bit helpful for that. How do you deploy it? Well, first you got to put your tube down. Make sure you get a chest X-ray before you deploy any of the balloons to confirm that you're in the right place. You then will blow up the bottom balloon, the stomach balloon, which is done by volume. And you're going to blow it up nice and large with 300 cc's of air. And you're going to then pull it back against the stomach JE junction. And what this does is the pressure that you're pulling back on will stop blood from getting from the stomach into the esophagus. Hopefully that'll work, but if it doesn't, you have the second balloon that you can blow up, which is in the esophagus, and that'll tampen out bleeding from into the esophagus. The numbers you need to know are 300 cc's go in the belly balloon, the stomach balloon, and 40 milligrams of mercury is used in the esophageal balloon. But I never remember these numbers. I'd always have to look it up every time. Make sure you do too. Here's a picture of a person from the old C1 that we put one in. This one was just tension tied. And basically what we did was just use a pole or use cling to pull it up against the stomach wall. But the more common way to do it is just to take a liter of saline and hang it over an IV pole so that tension, the weight acts as a tension device and pulls it back. Back in the old days, we did have a football helmet in CCT where we tied the tube to the football helmet, but we don't really do this anymore, and the helmet has gone. Surgical treatment is kind of a last resort. If you're going to put the person on the table, make sure you reverse all their coagulopathic problems. What they want to do is they want to devascularize the lower esophagus and the upper stomach. And people, what they do is a staple gun transection, where they just run a line of staples across the esophagus, across the stomach, which stops blood flow back. And then finally, the big surgery you eventually want to do is your liver transplant. So let's review. Mallory-Rice tear is usually self-limited, not a big deal. Gastritis and peptic ulcer disease you want to treat with your belly meds. H. pylori gets quadruple therapy. This is infecting 50% of the world population. GI bleeds, foreign bodies definitely can be crazy in what you see. Varices is probably the worst form of GI bleeding that we don't want to see. Cirrhosis leads to portal pressure increases and also anticoagulation due to liver failure. The Glasgow Blackshear score is a very good score that tells you if you need an intervention, and it tells you who is safe to discharge home, but not mortality. Endoscopy should be done within 12 hours for varices at a maximum. Octreotide vasopressin will decrease the portal pressures and help with your bleeding. Your Blakemore tube is your last resort, and it's the volume balloon first, then the pressure balloon, and then tips if they survive. So I thank you guys all for listening. I know I spoke fast. There's a lot of data in there. I'll take any questions you guys have right now.